My name is Gabriela Luzuriaga Maldonado, and now I'm going to talk about direct oral anticoagulants for thromboprophylaxis in ambulatory patients with cancer. About definition, deep vein thrombosis is a condition that occurs when a blood clot forms in a deep vein. These clots usually form in the lower legs, thighs, or pelvis, but they can also appear in the arm. Patients with cancer commonly have a venous thromboembolism during the course of their disease.
So a patient led our talk today on cancer-associated thrombosis, and we haven't really paid much attention in years gone by to thrombosis, which is a clot in the leg or the lung in cancer patients. But now with the sophistication of CT scans and cancer, looking for responses in patients who've had treatment to cancer, we're picking up many more thrombosis on these scans, and also with some of the fancier drugs and the newer drugs we're using, we are picking, they increase the risk of clots in cancer patients. So the tumor can cause the clot, the chemotherapy can cause the clot, increases risk, but also a central venous catheter, that's a way of giving chemotherapy, and some of the new drugs as well.
About applications in medicine, several factors expose these patients to thrombotic complications, from the prothrombotic state related to the malignancy itself to cancer treatments, chemotherapy, radiotherapy, or surgery. Cancer patients on anticoagulant treatment have a higher risk of fleeting complications compared to no-cancer patients. Most current clinical guidelines recommend low molecular weight heparins as the treatment of choice for cancer-associated venous thromboembolism. But there are problems regarding the long-term use of low molecular weight heparins as daily subcutaneous injections and their associated costs. Direct-acting oral anticoagulants such as dabigatran, rivaroxaban, apixaban, and edoxaban have shown similar efficacy and a better safety profile compared to vitamin K antagonists. Now about pros and cons. Pros is a clinical benefit that reduces the number needed to treat and avoid an episode of venous thromboembolism. Thromboprophylaxis with direct oral anticoagulants in ambulatory patients with cancer are effective and safe. About cons, the use of thromboprophylaxis is recommended only in high-risk patients. Regimens or predictive scores are needed.
I'm Thomas Baldrick at ASH 2015. Happy to have with us Dr. Alok Khurana from the Cleveland Clinic. We appreciate you, sir, for coming by.
Thank you.
Let's talk about a study of yours, current practice patterns and patient persistence on anticoagulant treatments for cancer-associated thrombosis. What are the major factors with this particular work?
So, low molecular weight heparins, which are daily self-injections, have been recommended for about 10 years as the best treatment for cancer-associated thrombosis. And that's recommended by the ASCO guidelines and the NCCN guidelines and so on. But nobody really knows what's happening in the community. And challenges with using that specific class of agents is it's an injectable, so it's a daily self-injection. And especially in the US, the cost of daily self-injections can be prohibitive, and direct-to-patient costs can also be challenging. In recent years, other anticoagulants have come on board, and so we decided to do a study to see what was happening in real-world setting, what were patients getting prescribed. What we found was that about half of patients were still getting warfarin, which, certainly low molecular weight heparins are better than warfarin, and many people would argue that the novel oral agents are also at least as good and maybe slightly better than warfarin. But despite those recent studies, warfarin remains the dominant anticoagulant used in the current setting. About a quarter of patients were getting rivaroxaban, which is a newer oral anticoagulant, and a quarter of patients were getting low molecular weight heparin, which is the guideline-approved treatment in this setting.
What were the key results?
We found that cancer patients, first of all, even though VT is generally manageable in the outpatient setting, only about 10% of patients were getting managed, diagnosed, and treated in the outpatient setting. The majority of patients were getting either emergency room visits or getting full hospitalization, sometimes as long as 6 to 8 days. And that, to me, is really surprising. There's a lot of drugs available that we could just treat patients in the outpatient setting. Most patients with blood clots, DVT, even many PE patients are really safely managed in the outpatient setting. At the Cleveland Clinic, we do this all the time. We have a centralized service that just takes care of cancer patients with blood clots. So I'm surprised that many patients are being hospitalized when they don't really need to be.
How do you explain that 10% number?
It's very surprising to me, and I don't know that I have a good explanation. I think part of it is just logistics. Many community-based practices are sort of far-flung. If a patient calls with symptoms of a blood clot, they might just say, hey, go to the emergency room or go into the hospital because that's the easiest way to manage this. Whereas in larger cancer centers, you could bring them into a walk-in clinic or some type of specialized service. So that may be part of the explanation.
So what does the data in this study show you?
It shows that, in general, first of all, we should do a better job of managing these patients in the outpatient setting. Second, we should be more compliant with the guidelines which recommend low molecular weight heparin monotherapy. And really, it's time to move away from using Coumadin. There's a lot of drug-drug interactions. There's a lot of, there's some bleeding risk associated with Coumadin. So it's important we sort of, take into account the newer treatment paradigms for this illness.
Where's your future look for this?
Lots of ongoing trials comparing low molecular weight heparins head-to-head with rivaroxaban or with other novel oral agents. So those studies should be coming out soon. Those data presented at ASH today about use of rivaroxaban at a couple major centers. Sloan Kettering was one of them, and it looks like it's okay to use in select patients. So I think sort of developing more nuance and which patients should be treated with which agent is sort of the next step.
Dr. Kreiner, let me just ask you your opinion of the data presented here at ASH. What are your thoughts on it?
I think we are finally making trends toward a more patient-friendly approach, which is we don't want to treat all patients the same way. We want to find the high-risk patients. We want to treat them with more intensive anticoagulation strategies. We also want to find the low-risk patients, and we want to treat them with less intensive and more patient-friendly strategies.
Thanks again. Appreciate your time.
Thank you.
About issue applied in Ecuador. In Ecuador, the management of thromboprophylaxis in oncological patients is based on clinical guidelines and study recommendations that have been shown to be effective in preventing it. Apixaban and rivaroxaban have been added as thromboprophylactic options for high-risk outpatients with cancer without significant risk factor for bleeding or drug interaction.
Patients with cancer have an increased risk of venous thromboembolism, but parenteral thromboprophylaxis is not routinely recommended in practice guidelines because the absolute risk reduction is modest and parenteral thromboprophylaxis is associated with an increased risk of major bleeding, as well as the inconvenience of daily injections. Could a direct oral anticoagulant such as apixaban, used as a thromboprophylactic agent in patients with cancer, offer advantages over parenteral agents, particularly with regard to convenience? The randomized placebo-controlled double-blind AVERT trial included ambulatory patients with cancer who were at intermediate to high risk for venous thromboembolism with a Corona score of 2 or more. The Corona score has been validated to identify patients with cancer who are at elevated risk for thromboembolism. The trial patients were randomized to apixaban for thromboprophylaxis before chemotherapy or to placebo before chemotherapy. The primary outcome was objectively documented venous thromboembolism over a period of 180 days. In a modified intention-to-treat analysis, venous thromboembolism occurred in 4.2% of the 288 patients in the apixaban group and 10.2% of the 275 patients in the placebo group. The number needed to treat to prevent venous thromboembolism was 17. The main safety outcome was major bleeding. Major bleeding occurred in 10 patients in the apixaban group and 5 patients in the placebo group. The authors conclude that apixaban at the initiation of chemotherapy resulted in significantly lower rates of venous thromboembolism than did placebo among intermediate to high-risk ambulatory patients with cancer. The rate of major bleeding episodes was higher with apixaban than with placebo. Full trial results are available at nejm.org.
Finally, the conclusion: the incidence of venous thromboembolism is 6 times higher in patients with cancer than in patients without cancer and is associated with significant morbidity and mortality. The majority of seriously cancer patients require thromboprophylaxis during their hospitalization, provided they don't present with bleeding or other contraindications. And drug thromboprophylaxis can be offered to hospitalized patients with an active malignancy without additional risk factors.
Venous thromboembolism is a common complication of cancer. While subcutaneous low molecular weight heparin is the standard treatment for cancer-associated venous thromboembolism, the role of direct oral anticoagulants is unclear. A randomized open-label non-inferiority study of 1,046 patients with cancer and confirmed venous thromboembolism tested the efficacy of anticoagulant therapy for up to 12 months. One group was treated with subcutaneous low molecular weight heparin for at least 5 days, followed by 60 milligrams of oral edoxaban once daily. The other group received 200 IU of subcutaneous dalteparin per kilogram once daily for 1 month, followed by 150 IU per kilogram thereafter. The primary outcome, a composite of recurrent venous thromboembolism or major bleeding event during the 12-month follow-up, occurred in 12.8% of the patients receiving edoxaban, as compared with 13.5% of the patients receiving dalteparin. Statistically, this result demonstrated the non-inferiority of edoxaban to dalteparin, but did not demonstrate its superiority. Recurrent venous thromboembolism occurred in 7.9% of the patients receiving edoxaban, as compared with 11.3% of those receiving dalteparin, and major bleeding occurred in 6.9% of the patients receiving edoxaban, as compared with 4.0% of those receiving dalteparin. The authors conclude that in patients with cancer and venous thromboembolism, oral edoxaban was non-inferior to subcutaneous dalteparin for preventing the composite outcome of recurrent venous thromboembolism or major bleeding. Edoxaban's lower rate of recurrent thromboembolism was offset by an increased risk of major bleeding. Full trial results are available at nejm.org.
Thank you.